your question. Right. So if you've read and understood, considering a critical care scenario, please tell me, how would you manage this patient?
Okay, ma'am. So it looks like a patient with traumatic brain injury secondary to traffic accident. So I have to start with ATLS, Advanced Trauma Life Support Protocol. So I have to check ABCD, airway, breathing, circulation. So I will talk to the patient if the patient is able to talk so that I can understand the airway is pattern. If not, then I have to look for any foreign body in the mouth. Then I have to fix the neck, cervical spine with sandbag and tape. Then I can put on oxygen via nasal prong or via face mask. If I have to check for breathing, any obvious trauma on the chest, is there any open wound is there or not, any rib fracture? Then I have to look for circulation. Is there any obvious bleeding or not? We can open IV line and then start fluid.
In your case, patient had or came with the Glasgow Coma scale of 15, vomited twice, and now patient's Glasgow Coma scale is 8. What would you
Mm.
do now in this current scenario?
So now, then after this first assessment, then I have to send the patient to CT scan of brain and spine.
And you won't do anything to manage the ventilation of the patient?
Yes, ma'am. I have to intubate the patient and then admit to ICU after done CT scan.
Okay. So what is the criteria to follow according to the NICE guidelines in order to send the patient for CT scan?
So if GCS is less than 13 at any point of injury, if GCS is less than 15 after 2 hours of injury, if
Yes.
there is vomiting more than 2 episodes,
Yes.
if there is height like more than 5 stairs or 3 meter, if the patient age is more than 65, if there is any sign of basal skull fracture
Okay.
like otorrhea, rhinorrhea,
Good.
or any battle sign,
Kindly tell me, what is the normal value of intracranial pressure
is 7 to 15 millimeter of mercury.
in spine position? Okay. Are there any ways you can tell me by which you can measure intracranial
Yes,
pressure?
it can be measured in some invasive and non-invasive way. So non-invasive, we can do transcranial ultrasound, we can do tympanic membrane displacement, and invasive, we can do intraventricular catheterization, we can do subarachnoid probe, extradural probe.
Subdural catheter. Okay, good. Can you tell me what are the dangers which are associated with doing lumbar puncture in patients with increased intracranial pressure?
Uh, Chance of brain herniation and coning.
Good. Can you tell me what you understand by the term Cushing reflex?
Um, is a symptom complex after a trauma or anything if increase of intracranial pressure. So the symptoms are the signs are increased blood pressure, bradycardia, and irregular respiration.
What do you understand by the term lucid interval?
So lucid interval is the temporary time frame where the patient had a temporary improvement of the consciousness after a trauma. and then sudden deterioration of the conscious level.
Can you tell me the pathogenesis of increased pathogenesis behind the, or the pathophysiology behind increased intracranial pressure?
Okay, ma'am. So our skull is a closed box where
Yes,
the contents is brain 80%,
yes.
10% is blood, and 10% in CSF. So it has a autoregulatory system, but increase any amount of one of them can, after beyond the autoregulatory system of the body, can increase the intracranial pressure.
To around what level?
Is
25.
more than 25
Yes.
millimeter of
And
mercury, patient will
this
show sign symptom.
phenomena is also widely known as
Is Monroe-Kelly doctrine
a doctrine
hypothesis.
hypothesis. Very good. All right. Can you tell me what happens if you fail to manage this patient? What are the complications that you should expect to see?
So, due to increase intracranial pressure, patient will have hypoxic, and patient's cerebral perfusion pressure will be decreased. Patient will be herniated, and then blown pupils. So, patient might have neurological symptoms, aphasia,
Yes. All right. Can
and
you please tell me what are the indications for intubation of the patient?
so if the GCS is less 8 or less than 8,
Yes.
if the patient need ventilatory support for any reason like trauma, mandibular fracture, facial fracture,
Okay.
if the patient have multi-organ failure, sepsis, ARDS.
Yes. Yes. Good. What are the advantages of trachea?
So if a patient having any obstruction in the upper airway, so immediately we can do a tracheostomy to open the airway, and it also worked as a weaning of the ventilation, so it will decrease the airway space.
Right. Can you please tell me how would you take care of the, yes, how would you, with the help of medications, take care of the increased intracranial pressure?
Okay,
What diet
so
would you suggest?
okay, we can give osmolar diuretics like mannitol, or even we can use maybe furosemide as well.
Okay.
So other
Right.
than diuretics, we can use sedation to decrease basal metabolic rate, and we can decrease temperature as well.
All right. What else can you do? Would you
Okay, we can
consider?
intubate the patient, and then we can position the head up 30 to 40 degree.
Yes.
Then we can do hyperventilate for decrease the partial pressure of carbon dioxide, so that it will decrease vasodilation and decrease intracranial pressure.
You'll
We can
restrict,
give,
yes, you'll restrict the fluid as well in order to
yes,
prevent
will
cerebral
decrease the
edema.
fluid. Yes, ma'am. And then for surgical, we can do either burr hole or decompressive craniotomy.
Okay. Right. Not for this particular patient, but if you would have to do the lumbar puncture, what are the layers that needle will traverse?
Okay, so skin, then subcutaneous tissue, then infraspinatus ligament, and then uh, ligamentum fleba, and
Yes.
then subdural.
Yes. Okay, good. Yes, then the layers and then the meningeal, middle meningeal. No, that is, yeah, for the burr hole. Okay. Yes. I had to ask you that other one. Okay. All right. Good. All right. So in this patient, if you have done the CT scan, how do you expect it to be? Can you read this CT scan for me, please?
Okay, ma'am. So this is a hyperdense lesion by convex shape on the right parietal region
Yes.
with a midline shift and compressing the ventricles.
How would you differentiate? Um this CT scan with the patient with subarachnoid hemorrhage?
So subarachnoid, will be no convex shape. It will be like a zigzag manner on the fold of the durameter.
Okay. Right. Thank you.